So, can you share with us some things, Dr. Hanna?
I don't know what to say, really. I just want to thank you, Charles. I mean, I think and thank everyone who, instead of going out at Friday night, came here. And I know it's not a fun movie, it's a sad one. And I don't know, I think we all cried in here. I really appreciate what you have done. This is amazing. Because I think awareness is so huge for this disease. Because I think part of it is us. We are the problem, the specialists, that we are not educating the primary cares about this. And I think we should go out more and educate the primary care about this disease, because if we can catch it early, we have a much better chance of helping the disease and helping the patient and put it in much better remission than when we see the patients, 6 months, a year, 2, 3, 5, 10 years after the disease. So really, that's the awareness part that's very important. The other important part is the financial part. I mean, how to help this disease. And that's one other major problem, is like what Nancy said, the insurance don't pay, most of them don't pay, and the one who pays, they pay you less than the cost of the treatment. And this is what really, hopefully, this movie can help achieve, is awareness out of everybody, out of the insurance companies, to try to maybe reimburse the doctors. So hopefully we can just bill insurance, and they can pay for it. I'm not sure why that is so difficult. I think what we are trying to do is one major point actually that really affected me is with Hanna. I think about a few months ago, when Hanna's best friend died, she actually committed suicide. And Hanna's best friend had CRPS. And Hanna was very depressed, and she wanted to take her life. And that was a very sad day. And I guess me and all my teams were very touched by this. And I guess since that day, we all sit down and we make really a decision that we do not want any patient to not be able to get that treatment, no matter what. And we're opening the door to anybody, And I talked to Nancy, and Nancy has been very helpful. And also I'd like to thank Jim Roach from RSDSA, who came here also to help, and there's another organization that they help educate a lot of patients about RSD. And I think really from the day, I'm trying to take it as a mission to try to help every single patient and educate, as many doctors, so we can see the patients early and try to treat every single patient. And I don't know how can we get the finance away from it. I'm sure Hanna is in heaven, joined her best friends. So anyway, I really don't know what else to say. It's a very sad illness that affects our life. And I'd like to thank my wife, because I bug her every night about my stories. I think it was Laura who asked that question, which is why me? And that's the most difficult question that I think we all ask when it comes to pain and suffering. Why me? And I wish we had a simple answer to that. But, I'm sure there is answers, somewhere. And I'm sure God has a better life for us, or for Hanna, in heaven. So, anyway, it's a difficult thing. It's a difficult disease. I don't want to make it too sad. But, I would like to answer any questions. Yes? Okay, ketamine actually works on certain receptors, in the brain called NMDA receptors. It works also on cells called glial cells. It blocks the release of chemicals that are kind of like toxins. Those chemicals go into the nervous system all over the body. So they go to the small fibers, because it causes what we call small fiber neuropathy. So it can damage the nerves all over the body. Goes to the blood vessels. That's why patients get like, color changes, vasoconstriction, vasodilatation. Goes to the skin nerves, so sensitivity, the pain. Goes to the gut, the GI tract, the nerve endings in the stomach and the intestine, and it causes the gastroparesis. The blood vessel causes what we call POTS syndrome, Natalia has, and makes the patient very dizzy when they stand up. So basically it is a nerve problem, and ketamine works on blocking the release of those chemicals that cause that nerve damage. And it was very interesting that, we had, a patient that we injected ketamine, their foot was very cold blue, and we had a thermography camera that measures the temperature. And even though ketamine actually is what we call sympathogenic, which vasoconstricts, but because it works with a different mechanism in the brain, we actually after 10-15 minutes we saw the foot or the leg red, and there was at least 5 to 7 degree difference. So it really just works in the brain and stops the release of all those bad chemicals. Any question? Yes?
Do you know any medical teams that are currently working on some type of cure? I know you handle the symptoms and the pain, but is there any medical teams currently working on cure of this disease?
As far as I know, when I started ketamine, I took the protocol from Dr. Schwartzman, at Drexel University, and he's the one who started a lot of the studies and research for IV ketamine and CRPS. And I know they have been doing studies with some immunoglobulins right now, IgG, but again, with some success. There's nothing so far that is really magically cured for CRPS. But this is, as far as I know, just some IgG studies that do more research on the small fiber neuropathy with skin biopsies. Trying to find better medication that works on the same receptors with less side effects. And that's what most of the research is going on now. Trying to develop medication that are similar to ketamine, but actually patients maybe can take it as a pill. So they don't have to have IV, they don't have to go every few days to see the doctor or whatever. If we can find a pill that gives the same effect as ketamine without the side effects of being drowsy, that would be great. So that's what most of the research is going on now.
So do they need more funding to get a cure quicker?
Of course. Anything needs funding. Any research, needs funding. Unfortunately, most of the drug companies, they just look for the quick money and quick profit. So they're jumping now, I think, on like nasal spray, ketamine, or something that's already there, stuff like that. But to really find a new medication, it's very expensive to do that. So yeah, definitely funding, and hopefully this movie can just push a lot of people to help fund, more research for that illness.
Are there going to be some copies available you can buy, obviously, of the movie?
That's Charles' answer.
Well, the film is going to be like any movie. It's going to, like I said, even Michael Moore's film just hit the film festival circuit and won some awards. Now it's in theaters. So what we're doing first is film festivals. We want to win some awards, and then you look at the Netflix, HBO, Showtimes, all those things like that. So in a few months it'll be worldwide. So we're dealing with people right now in the UK for UK distribution through BBC and things like that. So it'll be worldwide. So they won't need DVDs. They can turn on Netflix and see it that way.
Any more questions? Yes? No, they're just using ketamine a little bit in a more aggressive way. You know, like in Mexico and some place in Germany, they're using what we call ketamine coma. So that they are able to give much, much higher dose, but they intubate the patient. They keep them for a week, 2, or even a month, you know, intubated, totally out of it, and then they bring them out very slowly. So, and that is not approved here in the United States. Yes?
What is your opinion of the ketamine?
I think it's good. There is some studies that show that it does help. My approach is a little bit different. I mean, we know that the higher the dose, the better the results. We know that the longer duration of treatment, the better the result. Even though some of the doctors were saying after 4 or 5 days of ketamine, if it doesn't work, then that's it. You know, stop using it. Well, in my experience, you know, just for the past few years, we had patients that after 10 days they only got minimal response, and you know, after 6 weeks or 3 months, we were able to have a great result. So we just need to be more patient and just change the idea of, you know, if it doesn't work in 5 days or 10 days, you know, that's it, it's not going to work. No. So we had a much better response with that. I rely more on physical therapy with the ketamine because a lot of those patients, their muscles are atrophied, they're weak, they're debilitated, bad nutrition, you know, they cannot do too much. So, you know, you put them in a coma and you leave them, you know, for months. I mean, we had a patient actually who got, you know, Clark actually, he got DVT, you know, deep venous thrombosis from, they did ketamine coma for him. So it has its risk, it's not without risk. Developed pneumonia, so it has caused some complications. We're trying to do something similar to that, where we make it, instead of 4 hours, we make it 8 hours, 10 hours. But then, you know, alternate it every other day, you know, and then have them do physical therapy in between. So that way, you know, we're achieving a longer duration and with physical therapy. So, you know, we're gaining motion, we're gaining strength. And what we're doing, you know, also different is we're using, you know, some muscle stimulation during the infusion. So during the infusion, we put the patients to muscle stimulation, try to strengthen the muscles, because otherwise patients cannot tolerate that. Those patients cannot tolerate anybody touching them. They cannot tolerate, I mean, all of you guys know, but for the ones who don't know, I mean, even air, you know, will hurt them. So, but, you know, we're able to do that under ketamine, is to put muscle stimulation, use those muscles and have them contract, while really they cannot do that without that. And have the ketamine not only pain relief, but actually it's like an exercise under ketamine. And that we've been seeing really good results with that. So there was a question here.
I have another question. Are you patiently followed also by psychologists and on psychiatrists? It seems like as was mentioned in the movie that Charles Long was having hallucinations and other patients as well to prevent the thought of suicide, not having suicidal thoughts.
No, hallucinations is just a side effects, it's a normal or common side effects from ketamine. And it's temporary, it's not a long-term problem. Ketamine is an anesthetic, so one of its side effects is hallucinations, you know, the bad dreams. But that's normal reaction, that's not anything that we worry about. Yes? They do require psych clearance because there's only one disease, psychiatric illness, schizophrenia, that ketamine may make worse. So we just want to make sure the patient doesn't have, you know, schizophrenia, so we don't worsen their condition. Yes. Yes?
Doctor, have you found better results in patients that are opiate-free than with people that are still using opiates?
Yeah, this is, you know, a little bit controversial, but you know, we believe now that opiates can increase pain, especially on chronic use like that, and that it causes what we call opioid-induced hyperalgesia, meaning that the brain becomes sensitive. Because opioid now, we believe that they cause inflammation of the glial cells in the brain, and those are a major component of the what we call central sensitization, where, you know, the whole body and the whole brain, spinal cord, becomes sensitive every stimulus that is usually, we feel touch as a normal touch, we feel it as a pain. And that is a result from the chemicals released from the inflammation of the brain cells, the glial cells. And we believe that opioids can increase that inflammation. So that's why we like to take patients off opiates and have them being off opiates. And actually now we use something called low-dose naltrexone, which is opposite to the opiate. It actually blocks the opiate receptors. And that has been shown to even help with inflammation of the brain glial cells and getting good response with that.